Thank you, Camilla, for the introduction. So I'm going to switch gears a little bit. And can you hear me? And I'm going to move on to serodiagnosis of tick-borne borreliosis. It's part of a broad effect on tick-borne diseases of diagnosis that we are focusing on at IDFISH, which is the technology arm, and IGeneX, which is the clinical arm. So this is based in California. As you know, tick-borne diseases are sometimes a subject of a lot of controversy, and particularly Lyme disease. There's been an awful lot of media misinformation, media hype in the US and so on, after it was discovered in Lyme in the US. Quite some time ago. So let's talk about the diagnosis. Lyme disease is caused by certain species of Borrelia, the genus Borrelia bacteria, and this is caused by bacteria of the Borrelia burgdorferi sensulata. So it's a group of bacteria belonging to this parent type, and these are called Lyme disease Borrelia. Lyme disease is transmitted by Ixodes hard ticks, and it's prevalent in temperate climate zone countries. So you see it in North America, Northern Asia, and Europe. Now, a related disease, tick-borne relapsing fever, or TBRF, I call, is caused by another group of Borrelia called TBRF Borrelia, or our relapsing fever Borrelia. And that's also a group of species. They have a much wider global distribution, usually transmitted by soft ticks, but Borrelia miyamotoi is also transmitted by Ixodes hard ticks. So the overlap, there is an overlap here. And of course, louse-borne relapsing fever, LBRF, which is prevalent in the Horn of Africa, is also a member of the TBRF Borrelia family, the species that is responsible for louse-borne relapsing fever, which thankfully is absent from the US and Northern Europe. Now, LDB and RFB possess distinct microbiological and genetic features, although they belong to the same genus. Now, the United States Centers for Disease Control and Prevention, CDC, estimates about 89,000 Lyme disease cases per year, and only 25 TBRF cases in the US per year. Okay. And you check the references up for that. So that's the background. Also regarding their diagnosis, there is a geographical overlap of Lyme disease and TBRF, because I'm going to talk about the diagnosis of both of these a little bit. They share non-specific clinical symptoms, although clinicians would say the periodic relapses of fever in TBRF, which is caused by antigenic variation in the surface proteins, is not always discernible. This is characteristic of TBRF. And some physicians say it's very easy to distinguish TBRF from Lyme disease. Lyme disease has characterized by an erythema migrans rash, which is a bullseye-like appearance at the site of the tick blood feed, and it's an indicator of early or localized Lyme disease, but it's not always present in all cases of Lyme disease. The long-term pathology of Lyme disease and TBRF can be different, and there is a more severe reaction, the Jarisch-Herxheimer reaction, when you do antibiotic treatment in TBRF in the Lyme disease. So there are some differences which are important, and the clinicians would elaborate on that, I'm sure. Now, the diagnosing borreliosis is difficult. Now, PCR is sensitive in specific situations like skin biopsy during the early stages of Lyme disease when there is a EM rash, in synovial fluid when you have Lyme arthritis, and in blood during acute fever when there's high bacteremia in TBRF. Otherwise, TBRF is insensitive because Borrelia, particularly the Lyme disease Borrelia, tend to sequester in tissues, but also TBRF disappears, relapsing fever Borrelia disappear from the peripheral circulation in low bacteremia. There is evidence for biofilm formation and so on. So microscopy of blood has the same shortcoming, not easy to do with bacteria here. And culture identification of Borrelia is difficult because they don't culture well. We now have fairly good cultures, but they take a long time. Since the 1980s, the diagnosis of Lyme disease has relied on a variety of serodiagnostic tests. TBRF is mainly clinically diagnosed, and no diagnostic tests have been previously established. And of course, the disadvantage of going for serology is the detection of serum antibodies does not distinguish between an active, resolving, or resolved infections, because antibodies do last for some time. And if you have poor tests for diagnosis, you can have, for borreliosis, you can have misdiagnosis or even no diagnosis. So this has been a persistent problem in the US. Now, there's some complexity to the serodiagnosis of Lyme disease. Lyme disease is caused by in the US is by Borrelia burgdorferi sensu stricto or BBSS. Other Lyme disease Borrelia are detected in ticks and animals in the US, but in Europe, there are a number of other well-known species, Afzelii, Guerini, Spielmanni, and borreliosis, which besides BBSS, that can cause Lyme disease. And Afzelii and Guerini has been reported in Mexico, possibly in California, and it'll be extremely surprising intuitively to say that they're absent. It would be very surprising to say they're absent in the US. Guerini, Afzelii, and borreliosis and potentially other LDB species cause Lyme disease in Asia. There are antigenic differences between homologous proteins from different Lyme disease species. And this means that you need to perhaps use antigens from multiple species to better get a comprehensive diagnosis of Lyme disease. And if, as in the US, you deny there are any other human infections due to other than BBSS, then you have a problem. Now, the criteria for detecting for serodiagnostic positive tests for Lyme disease was established some years ago in the 1990s in the US as a result of a CDC consultation. And this involves two tiers of tests. The first test is an enzyme immunoassay, or sometimes an IFA, immunofluorescence on whole cell lysates or cells of BBSS. The second tier test, if the first tier test is positive or equivocal, then you need the second tier test to establish specificity. And this involved, according to the CDC definition, reaction with 2 of 3 BBSS antigens, and for IgG antibodies, any 5 of 10 BBSS antigens, which are characterized by their molecular weights. P18 typically has a molecular weight of 18 kilodaltons. A positive IgM Western blot test, according to the CDC, was indicative of recent infection and is valid for infections that are thought to be less than 30 days old after the onset of symptoms. So it's quite complicated. It's not straightforward at all. And this caused an awful lot of problems over the last 20 years in the US. Now, what I would like to talk about the advances. The US FDA now approves modified 2-tier tests because the Western blot test, which involves growing Borrelia in culture, lysing them, and running a Western blot on whole lysates of whole bacteria is very complicated. And, proteins do migrate differently in complexes. So now they offer, FDA has approved modified two-tier tests, with, for example, using two different enzyme immunoassays. And they also approved the use of recombinant antigens rather than immunoblots with whole cell lysates, which is a huge complex mixture, for these what's called the standard two-tier tests that the CDC approved in the 1990s. Europe has used the equivalent of the US standard two-tier tests, but they also recognize that Borrelia guerini and Apzelli are also present together with BBSS. And so two different antigens of any species is considered a positive result in a Western blot. And they've switched to recombinant proteins using immunoblots. China is no widespread policy, but they were accepting a one-brand criterion for IgG and IgM with B. guerini in Western blots. So very complex. So what IGeneX did was to develop a immunoblot using purified recombinant antigens, recommended by the CDC, plus other new antigens. And we have here, for example, an IgM immunoblot. This is purified antigens separated on nitrocellular strips, so you don't need the whole bacteria. And this is picking up IgM antibodies, and this blot is picking up IgG antibodies. And you can see that overall patients 2 and 5 are positive by the CDC criteria. So 2 to 5 here are positive for and some of these are positive for IgM and for IgG. While serum 1 is negative IgM, but positive by the criteria used at IGeneX, which is slightly different from the CDC criteria. So it's a bit, also pretty specific. So this is the complexity that developed in the late 2010s. And the early signs indicated that as a standalone or single tier test, which is obviously preferable to a two-tier test involving two different tests and assays, the IGeneX immunoblot showed a sensitivity and specificity, which is quite good using the CDC recommended antigens without the 30-day limit for IgM. And also the IGeneX used two different proteins that were not in the CDC recommended list of antigens. So these suggested that a one-step test might be highly desirable and possible. Just to move away from Lyme disease, we'll come back to it. IGeneX also developed a TBRF immunoblot test using purified antigens from relapsing fever Borrelia. And this, the criterion used here was the recognition of flagellin B plus 2 of 3 antigens, BIPA, GLPQ, and PACTH binding protein. And this yielded a specificity, very high specificity and sensitivity, sufficient sensitivity. And if you do a test with rabbit antibodies raised against TBRF species, RFV species, and Lyme disease species, I think you can fairly see here fairly clearly. So these are rabbit antibodies, so they will be expected to produce a lot of good antibodies, immunization, not infected. They will produce a lot of good antibodies to whatever you immunize them with. So, so this is a TBRF immunoblot with different antigens from relapsing fever Borrelia. And this is a Lyme immunoblot with different antigens from Lyme Borrelia. And you can see that sera 1 and 2 are positive, which are derived from sorry. Oh, sorry, this is what I wanted to show first. So this is the TBRF immunoblots with rabbit antisera, and you can see that these here, 5 to 10, or 4 to 10 are different, where the antigens are from different Lyme disease species. 1 to 3 are from different relapsing fevers species. And if you react with rabbit antisera that are specific against relapsing fever Borrelia, they only react with the relapsing fever Borrelia antigens, except for flagellin B, which is cross-reactive between Lyme disease and relapsing fever Borrelia. And if you take rabbit antibodies raised against Lyme disease Borrelia, they only react with Lyme disease antigens and not against relapsing fever Borrelia antigens. So that indicates, it's a good indication of the specificity of the test. So going back to human serum from patients, and we can see that without going into too much details, that some of the patients, for example, 1 and 2 are positive for in TBRF immunoblots only. They only react with relapsing fever Borrelia antigens. 3 is positive in both relapsing fever Borrelia and Lyme disease immunoblots. Number 4 is negative in both. And number 5 is positive only in Lyme disease immunoblot here. In this case for IgG antibodies. Okay, so basically what we see with the rabbit sera, antisera, appear to be mirrored in human patient sera. So that's a bit of the background. So when we looked at these are patients with Lyme-like symptoms, okay, diagnosed by physicians as likely to have Lyme disease. And we looked at patients from Australia, Ukraine, and the US. And some of these were only positive in the TBRF immunoblots. Some were only positive, the sera were only positive in the Lyme disease immunoblots. And some were positive for both Lyme disease and TBRF. The conclusion is that here we have Lyme disease symptom patients. They may have TBRF as well, or they may have TBRF alone as well. Okay. And fortunately, the US FDA has approved the IgG test, which involves purified antigens. And in a single tier test, so it's one tier test, developed used by IGeneX. So this is containing the CDC antigens as well as the IGeneX antigens. So we have here a patient serum that's highly positive for Lyme disease and a patient that's highly low positive for Lyme disease. I won't go into the details of the antigen, but we have a reaction with what's called a Lyme screen antigen, which is a particular Borrelia burgdorferi antigen, and then reaction with a couple of defined antigens, 1 or more bands from as defined here. So a single tier test is possible and it's been FDA approved. And the conclusions are that single tier tests for Lyme disease and TBRF is now possible. The prevalence of TBRF in the US is seriously underestimated. And particularly in patients showing Lyme disease-like symptoms. And we have similar issues with other tick-borne infections where the signs and symptoms are very different to diagnose. And single strip IB tests for immunoblot tests for Bartonellosis and babesiosis are now available at the IGNX. And the Lyme immunoblot test is readily automated. And we also have a rapid flow test that is available and hopefully will be approved by the FDA soon. So essentially, I have a conflict of interest here, but basically IGeneX offers a highly sensitive and specific fast lateral flow screening test as well, using recombinant antigens and being developed for other tick-borne diseases. Thank you very much.